I'm Rachel Abbott. I'm part of the Family Medicine Residency Program, and I will actually be one of the presenters today for our presentation. I would also like to introduce Dave Neison, one of my emergency medicine colleagues. So we'll just take it away then.
Thank you guys for having us. Again, my name is David Neison. I know many of you I have not met. All of you, I'm sure I've taken care of some of your patients at some point. So thanks for letting us be here. This is something that is very important and relevant to us. 40 or 45 minutes, you feel the same way. And I apologize to people in my department who have heard me blabber on about this at length, but hopefully Rachel's point will be a nice fresh perspective.
I came to climate action personally a few years ago when I was on maternity leave with my daughter in 2018, and I saw a Scripps Institute article basically that said that they had recorded the hottest waters off of the Pacific, off of San Diego in the Pacific Ocean in decades, in over a century ever. And I had grown up in Southern California, and ocean temperatures were supposed to be cold in the Pacific Ocean year round. And yet they were saying this was 80 degrees in the Pacific Ocean. So this was alarming to me. And I started to take a lot of personal action to change my carbon footprint within my family. But I struggled on how to sort of translate this to my professional sphere until I attended a couple of conferences earlier this year, in which I was reminded that we are trusted voices as physicians in a lot of ways, which we will review throughout our presentation today, and that we'll summarize especially at the end, and that by me not taking action, I was actually causing harm to my patients and our community.
Likewise, I have always had an interest in quote unquote the environment, but really never knew how to translate that to my career. It was really kind of my work in disaster medicine that made me very aware of all the effects on not only disasters, but public health in general that climate has. And on a personal level, I grew up, camping in the Sierras with my dad. It's how I kind of fell in love with California, being from Houston. And I have, tried on many occasions to do the same with my sons. And on more than a number of occasions, those trips have been either canceled or evacuated due to wildfire and air quality. So I know it seems trite. Everyone kind of talks about their kids when it comes to climate, but we do really care about the planet that we leave behind us. So we wanted to start with kind of take the temperature of the room. So feel free to enter in the chat box or just reflect silently. But to you, climate change, A, keeps me up at night, B, concerns me, but I don't think about it daily, C, is a political issue that we should stay away from as a profession, or D, is fake news.
So again, feel free to participate in the chat, everybody. Okay, so I have one B, a couple Bs, okay, a couple As, awesome, thank you.
When it comes to climate crisis and medicine, A, I can definitely see the relevance. B, I've never really thought about the connection. C, I simply don't have time to address this with my patients. D, we are in the midst of a pandemic with hospital overcrowding, staffing shortages, and a crisis in access. Why are we even talking about this?
So again, B's and A's pretty much. So I think we have a group here that are relatively early adopters. I like to see that. Very open. Okay.
Yeah. So why are we talking about this? The reason we're talking about this is because everybody's talking about this. If you look at all these healthcare organizations and nursing organizations that have climate policy statements that say that climate crisis is a public health crisis. And if yours is not listed here, I urge you to look yours up. I guarantee they have a climate policy. And last month, something kind of cool happened. This was an unprecedented joint op-ed from over 230 medical journals, including heavy hitters like the New England Journal, British Medical Journal, Lancet, the leading journal of China and Brazil. And they all came together and called climate change the greatest threat to public health. And they really urged world leaders to take bold action ahead of the Glasgow summit next month. And why are we particularly talking to you guys? Because we think that education is really at the crux of this. I think it would be really tragic for our trainees to finish their residency and not have exposure and knowledge to the climate crisis, especially because we are Kaiser, and Kaiser, makes a name for itself on equity and sustainability and carbon neutrality. So it's a bus that's going to go. We either get on the bus, take the wheel, or we're kind of left behind, I like to think of. But the kind of objectives for this talk and the objectives for our trainees are as follows. We would like them to have basic knowledge of the health effects of climate change and all of the myriad effects it has on their health and their life. We would like for physicians to have the ability to guide their patients on healthier habits to reduce their greenhouse gas emissions, but also kind of mitigate the exposures to some of the health effects of climate change. And we would like to have some knowledge for them of disaster preparedness, and not just those that work in emergency medicine, but to understand the way that it affects our delivery of healthcare. We'd also like for them to understand the really heavy footprint that healthcare has in greenhouse gas emissions. It's estimated that about 9 to 10% of energy consumption comes from healthcare. So there's a lot of ways we can make things better. Even though Kaiser has achieved, quote unquote, carbon neutrality, there's many ways that we can make things better, and we often find that it's the younger generations that compel us to do so. We'd really like for them to understand the intersectionality between climate and public health and equity, because as we'll talk about more, this affects certain populations a lot more than me. And then lastly, we'd like our trainees to walk out of here with the knowledge and inertia to advocate elsewhere, whether they stay in Kaiser and make us better, or they go and they have a little inception in whatever healthcare organization they go to. So I wanted to start with something that's pretty current, which is the IPCC report from August, which was really high-level statistical analysis, but I will kind of break it down to a couple takeaways. And this is something that the UN Secretary General called a Code Red for Humanity. And the IPCC is a group of volunteer scientists from around the world established by the UN that's reviewed thousands of peer-reviewed studies. And their last report came in August of this year. And its takeaways were, one, is unequivocal that human influence has warmed the atmosphere, ocean, and land. And this is really the first time that they have used such bold language. It used to be highly probable, maybe, it's matter of fact. Number two, the last decade was the hottest decade in the last 125,000 years. Number three, some climate changes we have seen are irreversible. And I think for me, that's the hardest pill to swallow, that the current climate-related disasters that we're experiencing right now are possibly a best-case scenario if we do take bold action now. And number four, greenhouse gas emission being cause of climate change. Again, this is the first time they've been so matter-of-fact about this. And then 82% of that comes from carbon dioxide. And if you look at all of the sectors of the economy as broken down, healthcare really has our hand in almost all of these. And lastly, which is near and dear to my heart, climate events are increasing in severity and frequency in every region of the planet. So that's where we're going to start today. You may have heard the term, maybe for me, as the climate crisis as a threat multiplier, because it really increases the frequency, duration, and intensity of any threat that already faces a given population. And I think of this past summer as being a bit of an inflection point, at least I hope so, in our awareness of climate change and taking bold steps to climate action. In a lot of ways, similar to the previous summer, I think was an inflection point in a fight for racial justice in this country. And the reason I think this has been a landmark summer is because the really wealthy nations of the world, the ones that wield all the power, the ones that have the biggest carbon footprint historically and currently, have really felt the burn. Villages like this in Western Germany were washed away by climate-related flooding. We saw terrible fires across the globe, not only in the American West affecting air quality across the country, but terrible fires throughout Siberia and Mediterranean. And also these megastorms we saw this summer, including Hurricane Ida, which not only affected kind of the rural Gulf Coast, but actually maintained its strength as it went across the United States and wreaked havoc on big population centers in the Northeast. The picture on the bottom is actually in New Jersey from a hurricane that struck Louisiana. Here in San Diego, we look at the hazard vulnerability analysis, which is our top 5 threats, and it doesn't change much year to year. Obviously, number 3 has kind of been getting all the attention recently, but number 1 is still wildfires, and it's a distant number 1. So I'm going to focus a little bit on wildfires. So this is our new normal. Our wildfire season is almost year-round at this point. And there's always, and you can see the amount of acreage that has been burned in the past decade and a half has far exceeded historically. And that's in spite of all of the massive amounts of money that have been spent on mitigation and fire containment. And there's always kind of this debate, somewhat political, about how much of wildfire is related to climate change, how much of it is forest management. There's obviously things we could do to improve forest management. But this particular model attributes about half of wildfire damage to climate change. And so why is that? So obviously the hotter, drier conditions, the decreased snowpack in the winter, the strong winds and increased lightning that we're seeing even in the summer, and this positive feedback loop. Wildfires tend to kind of create their own weather. They create hotter air. The pollutants tend to blanket the sky and trap heat. And then they create their own carbon dioxide from all of the burning. In California in particular, about 45% of the California population lives in a high fire threat area, and that tends to be increasing every year as we tend to have a housing crisis and continue urban sprawl. Our wildfire season continues to increase. The amount of money we spend for mitigation, response, and damage continues to go up in the tens of billions of dollars. And if you look at this, this is a busy slide, I apologize, but if you look at the top 20 or largest 20 wildfires in the state of California, 18 of them have occurred since 2000, and 4 of them are continuing as we speak. So San Diego has really spared the last few years, but we are right in the thick of it. We are in the midst of a very dry climate right now after 6 to 8 months of very little rain, and we are experiencing intermittent Santa Ana winds, which puts us at higher risk. Our biggest fire in the last few years actually occurred in December, the Lilac Fire in 2017. So how does all of this affect not just wildfire, but other disasters affect our delivery of care? The burden will fall very hard on the healthcare system. We're a safe place where the desperate look for answers. Hospitals really can't close their doors. I think of COVID as kind of being a little bit of a dress rehearsal for these climate-related disasters. We've felt tremendous staff or supply shortages, not having swabs, elements of PPE, ventilator tubing. We dealt with volume surges, seeing patients in cars and tents and hallways. We had disrupted and interrupted access repeatedly, a lot of staffing shortages. So this gives us a good idea of what potentially could be coming. And it really kind of compels us to adapt and be a climate resilient organization. So now we kind of want to turn our attention away from the big headline grabbing disasters and talk about kind of the boots on the ground, day-to-day patient care by going through some cases of the many, many ways in which climate change affects human health. So my first case is an 82-year-old Caucasian male brought in by medics, presents after being found by granddaughter at home, altered, lying on the couch, last seen normal 2 days prior, with no signs of trauma. He has a history of hypertension, coronary disease, and a stroke. He's on amlodipine, furosemide, and aspirin. He lives alone in a private home in Descanso, former smoker, drinks 3 to 8 beers per day. Due to wildfire risk, SDG&E turned off its utilities 2 days prior. Fisher checked off his gun. Vital signs are as follows. And on exam, he's a tunded, diaphoretic, mottled, but has no focal deficits. So, any thoughts on this could be? Kind of think about your differential. Obviously, septic component, certainly metabolic, toxicologic with his drinking history. But this is kind of bread and butter heat stroke. And this is something I would see fairly regularly when I worked in East County. I don't see it quite as much at Kaiser, thankfully. because I think there's hospitals that they get to before they make it to us. But this is a pretty severe case of someone who lost access to AC, has multiple risk factors, which we'll go through for a heat-related illness. And this public safety power shutoff is really a meaningful thing in terms of delivery of care, and particularly for our home health folks who have to visit these folks, sure that they have access to oxygen and vents and suction and everything else that they need, as well as just keeping cool. So a heat wave is actually the most common cause of weather-related human mortality in the US. It's responsible for more deaths annually than hurricanes, wildfires, lightning, tornadoes, floods, and earthquakes combined. An extreme is weather that is substantially hotter and or more humid than average for a location during a comparable period of time. So if you remember back in July, there was this massive heat dome in the Pacific Northwest, and this the province of British Columbia called a state of emergency for temperatures that in Palm Springs would have been like a Tuesday, no big deal. So it really has to do with the infrastructure in place and how suited that climate is to these extreme weather. And also humidity plays a huge factor. So for instance, 88 degrees at 95% humidity is essentially the same as 121 degrees at 10% humidity. And San Diego is experiencing increased humidity in the summer. I felt it more this summer than I ever have before. And we're seeing more triple-digit days. And frankly, our homes and a lot of are not really built for this amount of heat and often lack AC. So when looking at extreme heat events, what do they increase? Well, they increase, obviously, heat illness like heat strokes and could be an exertion. They increase cardiopulmonary disease, as you'd expect, but also things you wouldn't necessarily think of, like preterm labor, interpersonal violence, suicide, and other psychiatric illness, and overall ED visits and mortality. And who's at risk? If you look at our case, he kind of checks the first 6 boxes here. Elderly, lives alone, did not have access to AC, cardiovascular disease, obesity, neurologic or psychiatric disease, athletes, and those who perform manual labor. He also was on a diuretic and a calcium channel blocker and was a heavy drinker. So lots of risks there. I also want to introduce the concept of a heat island, which Rachel will talk about a little bit more, but it's an urbanized area with limited green that experiences higher temperatures than the surrounding outlying areas around it. And a lot of that has to do with structures like buildings and roads that re-emit the heat more than the natural landscapes of trees and bodies of water that tend to absorb the sun's energy. So one of the major community level solutions that we have is shade trees, and we'll talk more about that. But other things that Kaiser and other organizations could do so easily would be extreme heat notifications, cooling stations, and then outreach to our most vulnerable populations. And then some building level solutions, there's many that we could do as an organization or our residences. I think the green roofs is particularly really cool. And then individual level solutions. So these are things that we do in the emergency department that can be done at home or in clinic. And keep in mind, of the 4 methods of heat dissipation, which I won't go through, radiation, conduction, and convention are really ineffective when the air temperature exceeds body temperature. And evaporation even becomes ineffective, which is our major way of sweating, of cooling, becomes ineffective when relative humidity gets above 75%. So my second case is a 37-year-old male who presents with 2 days of fever, headache, joint pain, and nausea. He denies any sick contacts or travel. He states he sustained multiple mosquito bites while jogging through Tecolote Canyon last week. He has no past medical history, very healthy and active. You see he's febrile, but vital signs are otherwise pretty stable. And he has no meningeal signs on exam, but he has limited range of motion of all major joints without swelling or erythema. So thoughts on what that could be? As my son said every time he sneezes, it's not COVID. This I was getting at, this is likely dengue or some mosquito-borne illness. So the ways that climate change affects infectious disease, there's really 2 main mechanisms. The first one is through waterborne pathogens. And I kind of want you to think of climate change as an increase in the intensity of the water cycle. So areas that get drought, get worsening drought, areas that get precipitation get heavier precipitation. So climate change increases these heavy downpours. These flood waters can become contaminated with all kinds of waste and pollutants, including pathogens, viral, bacterial, and parasitic. And there can be spillage of sewage water into our drinking water. And this is not just a third world issue. It's estimated that about 1 million cases of acute gastroenteritis in this country are due to contaminated drinking water. And you can see a lot of the climate sensitive pathogens there. And this is increasing after other disasters when you lose access to electricity, clean water, and sanitation. So after hurricanes and even wildfires, you can have contaminated water from that. And then the other one, which is the case that I presented, is vector-borne illness, and this can be mosquito-borne and tick-borne, and because of the duration of the warm season, the increased precipitation, there's a longer life cycle of these insects, which can then expand their geographical range. If you recall, a couple of years ago, we had a little Zika scare because we started to see a particular mosquito, the Aedes aegypti mosquito, which had really never been seen in San Diego. And the overall, it's estimated the overall mosquito season has increased by 76% in the United States. The most common vector-borne illness is Lyme disease in this country. We don't think of it too much here, but the incidence has doubled from 1991 to 2013, and a lot of that has to do with the increased geographical distribution of the Ixodes tick. And if you look here, as the case I presented, dengue, so we think of it more as a tropical related illness, and in 1990 that was correct, but by 2085 we expect this particular mosquito, the Aedes, to penetrate pretty far into the United States population centers, including Southern California. So ditto for malaria. It's thought mainly to be a equatorial illness, but we're expecting by 2050 that the Anopheles mosquito may have some endemic components within the southern United States. So lots of solutions. I just want to call attention to minimizing standing water. These drought basins for water collection are really popular. They're also and they're great for irrigation, but they're kind of a cesspool for mosquito and other insect larvae. My last case is a 32-year-old female who is 27 weeks pregnant, presents with headache, lightheadedness, nausea, and fatigue 2 days after a winter storm knocked out power to her home. So this is a G2P1 with gestational diabetes, lives in Julian with her husband and 3-year-old son. Her vital signs as follows. Little tachycardic, pretty tachypnic, but normal pulse oximetry. And on exam, she has no focal deficits, and she's alert, but she's a little bit slow to respond to questions. So kind of think about what this could be. So this is a case of carbon monoxide exposure, which you don't really think of as being particularly related to climate. But in times of power outages, which are becoming increasingly common, these poorly functioning generators and space heaters can cause carbon monoxide toxicity. And it's more common in poorly ventilated spaces. So people who kind of live in smaller quarters around more people and don't have such adequate ventilation. The pictures on the right are of a Texas winter storm that affected a lot of my family and friends, where a lot of them lost power for up to a week. It affected, I think, 1/3 of the state, and it also accounted for the largest carbon monoxide poisoning in U.S. history, in which 17 people and 1,400 were hospitalized. Probably a lot more because it's notoriously difficult to diagnose. Other toxic exposures that can occur from climate change. Coal ash in Hurricane Florence in 2018 disrupted all of these coal plants, and there was just heaps and heaps of coal ash that you can see off the coast of North Carolina and down through drinking water and rivers. And it resulted in arsenic, lead, and mercury poisoning. So increased incidence of GI complaints, ADHD, allergies, dermatologic complaints. And also in Hurricane Harvey in 2017 in Houston, the floodwaters caused a disruption of gasoline, which then leaked about 500,000 gallons into the surrounding floodwater. And one other form of toxicity that we don't really think about is algae and cyanobacteria blooms. So because of the warming water, the increased atmospheric CO2 and this nutrient dumping from fertilizers and pesticides and from runoff, it basically creates the perfect environment for them to flourish. And this toxicity can result in gastrointestinal, respiratory, dermatologic, and neurologic illness, and can even cause, there's one particular kind of cyanobacteria that can lead to respiratory paralysis and death. So solutions for this, primarily we just want you to keep these things in your differential. So again, of a social history to identify these risk factors. Overall, as a society, obviously the decrease in overall reliance on fossil fuels, holding industries accountable to the way that they contain and destroy waste, using alternative generators and cell batteries in the home, and the concept of microgrids and climate resilient buildings. So for the next case, I'm going to turn it over to Rachel for a little less gloom and a lot more doom, hopefully.
Less gloom and doom, hopefully. So we have 3 more cases, and then we'll summarize. So my fourth case is of a 4-year-old overweight African-American boy brought in by his father for 1 month of increased daytime fatigue and dyspnea during soccer. He started playing on a fall league about 6 weeks ago following a summer of record heat. His past medical history is relatively non-significant. He lives in Southeast San Diego in a rented apartment with his parents and 2 older siblings. They are low income but just above the poverty line. They have no private transport. His vitals are significant for a heart rate and respiratory rate at the upper limit of normal. His physical exam is significant for a systolic flow murmur and conjunctival pallor. When you get his labs back, he has anemia with a very low ferritin. So his diagnosis is iron deficiency anemia caused by malnutrition. His risk factors for malnutrition include living in a food desert in Southeast San Diego, living in a low-income family, and living in California during a drought. Climate change causes both malnutrition and exacerbates malnutrition in vulnerable populations for 2 primary reasons. First, climate change reduces short and long-term availability of nutrient-rich foods via acute extreme weather events like wildfires and flooding, and chronic climate events like drought, all of which reduce and destroy crops. This results in disruption of the supply chain, causing increased costs and further exacerbating vulnerable populations, especially those who live in food deserts. Secondly, climate change also affects the nutrient density of foods by causing a reduction in levels of protein and micronutrients in plants, and also reduced livestock and marine productivity. As this map demonstrates, the entire western U.S. is in a drought, thus affecting our food availability and the nutrient density of our food. In fact, yesterday, all of Southern California was added to our state's state of emergency due to drought conditions. Let's look at malnutrition from an equity lens by exploring food deserts. A food desert is a region in which a large portion of low-income households does not have easy access to a large grocery store. These neighborhoods have more convenient stores and fast food restaurants and are therefore exposed to poor quality nutrition at higher rates. Furthermore, low-income households are less likely to have private transport and therefore do not have access to higher quality nutrient-rich foods outside of their neighborhood. Children are uniquely vulnerable and at risk from malnutrition because of its impact on development. Children who experience poor nutrition are more likely to develop obesity, diabetes, hypertension, and heart disease. As this map from the USDA demonstrates, food deserts in San Diego are primarily located in Southeast San Diego, where many of our patients live. This cartoon is spot on as it demonstrates a few super important concepts. Number 1, that vulnerable populations like individuals and families who live in food deserts experience the health inequity of food insecurity more often. Number 2, that mild and moderate food insecurity, like again, those who live in food deserts, is paradoxically associated with overweight and obesity prevalence due to diets high in processed foods and low in nutrient diversity. And number 3, food insecurity is almost twice as prevalent in households with children than those without children. This puts children at higher risk of food insecurity and malnutrition. So let's connect nutrition back with climate change. Although this is a busy graphic, it demonstrates the interconnectivity between increasing greenhouse gases, climate events, equity dimensions, and nutrition outcomes. The reality is that all diets around the world impact global warming. In fact, food systems are responsible for a whopping 1/3 of global greenhouse gas emissions, highlighting how the food that we produce and eat affects our environment. A shift towards sustainable, healthful diets would help reduce health and climate change costs by up to $1.3 trillion by 2030 in the US alone. The good news is that we can be part of the solution. So nutrition is obviously a pillar of health and thus intrinsically in our wheelhouse as physicians. If we can counsel patients intentionally and often on sustainable plant-forward diets, we will improve their individual health while also affecting the underlying systems that cause health inequity and high emissions that exacerbate climate change. So briefly, what is a plant-forward diet? You can't counsel someone about it if you don't know what it is. So a plant-forward diet is filling our plates with more plant-based proteins and produce and less animal-based products and processed foods. If you look at the protein scorecard on the right, you'll notice that plant-based products like wheat, corn, beans, lentils, rice, and soy both cost less financially and produce the least amount of greenhouse gas emissions per gram of protein. They are also less inflammatory, less carcinogenic, and holistically better for human physical and mental health. A plant-forward diet is a rare win-win-win with respect to climate change, health equity, and individual health. And I'll share a quick anecdote that I use with my patients. 1 kilogram of beef produces 120 times more greenhouse gases and is more than 2 times as expensive as compared to 1 kilogram of cauliflower, which is actually a versatile meat substitute that's gaining in popularity. So by updating our illness scripts to include sustainable counseling and interventions, physicians can be an integral part of the solution to climate change. Let's go on to our second to last case. This is an 18-year-old Latina presenting with 4 weeks of sore throat, congestion, cough, wheezing, and mild dyspnea. She has been running more since cross-country season started in August. She's using albuterol several times a day. Her past medical history is significant for mild intermittent asthma and allergic rhinitis. She was born and raised in National City in a rented apartment that was built in the 1950s. She lives with her family, one parent of which smokes. She herself does not smoke. She doesn't use drugs or drink. She does, I'll go to the vitals now. Her vitals are significant for mild tachycardia, mild tachypnea, and a reduced oxygenation. Her physical exam shows mild labored breathing, mild tachycardia with irregular rhythm, decreased breath sounds bilaterally with very faint wheezing, expiratory, and she has nasal secretions throughout. Her peak flow is significant for being only 60% of the predicted value. So her diagnosis is an asthma exacerbation with allergic rhinitis. Her risks include living in an industrialized area now and throughout her childhood, being an athlete, being exposed to a summer of wildfire smoke and extreme heat, being exposed to indoor gas appliances in her old apartment, and the fact that minority communities and children are targeted by tobacco and e-cigarette companies disproportionately. So let's discuss how climate change affects air quality. Climate change causes high temperatures, which increase the presence of air pollutants like ground level ozone and particulate matter. Climate change causes longer allergy seasons due to increased carbon dioxide, increasing frequency and severity of aeroallergens like pollen, and climate change results in changed weather patterns of humidity, precipitation, and wind, which exacerbates natural sources of air pollution, which we'll talk about on the next page. Thus, these air pollutants result in increased prevalence and exacerbations of several diseases. So here are some types of air pollution divided by human-made versus natural sources. Human-made sources include things like pollutants from transit, waste management, agricultural practices, industry, and energy production, whereas natural sources include pollutants from wildfires, volcanoes, sand and dust storms, methane from livestock, plant pollen, and biological decay. The most common harmful pollutants to humans are ozone and particulate matter because they can pass through barriers like the nose and mouth and enter deep into our lungs and circulatory system. And they can even cross the placenta to affect the growing fetus. The primary sources for ozone and particulate matter are vehicle exhaust, gas vapors, industry and energy factories, construction, and combustion of fossil fuels. Ozone and larger particulate matter like PM10, which is depicted on the right, primarily cause upper respiratory tract and upper lung symptoms, whereas smaller particulate matter, like PM2.5, primarily cause lower lung, cardiac, and fetal complications. In California, as Dave mentioned, a major natural source of air pollution is wildfire smoke, as demonstrated by this Air Now app. You can see that last week, Santa Barbara fire smoke was actually carried by the wind all the way down to San Diego, causing several areas of poor air quality, as demonstrated by the yellow dots near the border. Wildfire contains several pollutants that are known lung and skin irritants, neurotoxins, and carcinogens. So returning to our case, I wanted to highlight two key health conditions affected by air pollution. Asthma affects about 1 in 12 people in the United States and is associated with air pollution. Air pollution is associated with reduced lung function, increased use of rescue meds, increased emergency department visits, and hospitalizations. Asthma also disproportionately affects African American and Latinx children, largely due to the increased burden of traffic-related air pollution and ozone in their communities. Climate change also exacerbates other atopic diseases like allergic rhinitis. Allergic rhinitis affects about 10% of the US population currently, and the prevalence is increasing as is the frequency of exacerbations. As demonstrated on the left, carbon dioxide is known to expand the territory of pollen-producing plants and the concentration of pollen allergens. The top map on the right demonstrates the current tree distribution in the eastern United States, with the orange and red areas indicating trees with high allergenicity. If we can rapidly reduce global emissions now, the graph in the middle demonstrates that by the year 2100, the territory of these highly allergenic trees will expand only moderately. However, if we continue on the high global emissions track, most of the eastern United States will be covered in highly allergenic trees by 2100, as demonstrated on the map at the bottom. So you can imagine how all of the downstream effects of this on the healthcare system. In summary, climate change worsens air pollution, which in turn worsens human health. The adverse health effects, occur throughout the human lifespan from in utero through senescence. And they include things like obstetric complications, developmental delay and cognitive decline, increased respiratory symptoms, exacerbations of skin conditions like eczema, increased atherosclerosis, heart attack, stroke, increased exacerbations of asthma and COPD, lung cancer, and there's research being done currently on an association between head and neck, GI, and breast cancer and air pollution, and finally, premature death in people with heart and lung disease. So again, let's focus more on solutions and what we can do. So I recommend updating our illness scripts. As I mentioned earlier, these are mental notes we keep about certain diagnoses. We must include a climate change lens when considering illness risk factors. We can prescribe free interventions like the use of this Air Now app on the left, the Allergy Alert app on the right, and we as individual practitioners and also Kaiser system-wide can put into action air quality alerts so that patients know when to reduce their outdoor activity to prevent their own disease exacerbations. We can also recommend resources like programs that subsidize particulate matter sensors, electric vehicle ownership, HEPA filters, solar panels, air conditioners to help give our patients the tools required to improve their own indoor and outdoor air quality. So let's move to our final case. This is a 26-year-old G1 P0 at 34 weeks pregnancy with about 2 weeks of increased anxiety and palpitations with 1 day of more frequent contractions. She has no loss of fluid or vaginal bleeding. She recently hiked Mission Trails with visiting family for the scorching 4th of July weekend. She has a past medical history significant for untreated anxiety. She lives with her husband near San Diego State University, where they're graduate students. Her vitals are normal. However, her exam demonstrates a nervous affect, poor eye contact. And when you're doing her fundal height and fetal heart tone exam, which is normal, you notice a yellow bruise on her right flank. She's contracting about every 5 minutes, and she has a cervical exam that shows about 1 centimeter dilation. When you screen her for mood disorders, she screens positive, moderately positive for anxiety and minimally positive for depression. She has passive suicidal ideation with no plan. So her diagnosis is heat-related anxiety, depression, and suicidal ideation. She's also the victim of intimate partner violence, and she may additionally be experiencing preterm labor. Her risk factors for having this mood disorder exacerbation and being a victim of intimate partner violence include pregnancy, prior history of mood disorder, and a summer of extreme heat exacerbated by her living in an urban heat island around SDSU. The mental health effects of climate change have been well documented and include increased eco-anxiety, anxiety and depression, social isolation, PTSD, substance abuse, suicidal ideation and completion, and intimate partner violence, as I referenced. Furthermore, there is more than 3 decades of research documenting a clear association between increased heat and aggressive thoughts and behavior, including family disturbances, suicide attempts and completions, rapes, assaults, social and political uprisings, and even law enforcement intervention that escalates from a minor dispute to violent assault and homicide. International studies have consistently found that violent crime increases about 10% for each 2.5 degree increase in temperature. One theory is that the rise in temperature modulates serotonergic transmission pathways, which may increase arousal and impulsivity, resulting in increased risk of violent incidents. So climate anxiety is defined as a concern about climate change and its effects. And in the chat, some of you have some of this. Over 67% of Americans have climate anxiety. Over 50% of Americans feel climate change is the biggest threat to our society. And up to 75% of global youth aged 16 to 25 feel that the future is frightening due to climate change. Disturbingly, a majority of youth feel that they have less opportunity than their parents did, highlighting a grim reality that adults have created a less livable world for their children and future generations. So again, let's talk about some solutions. The beautiful elegance of this is that most climate solutions also benefit mental health. So I've shared some of my favorite solutions here with you, and I share a lot of these with my patients as well, including active transit, public transit, accessing green spaces, making sure that they're reducing their own personal carbon footprint, and sharing stories of creative and positive climate action. One of my favorite podcasts for this reason is How to Save a Planet, and I highly recommend it to all of you. These solutions are proven to reduce stress, mood disorders, social isolation, while also improving physical health and cognitive function by reducing community greenhouse gases and air pollution. Although we have interwoven equity throughout today's presentation, I wanted to explicitly take a moment to delineate the connection between climate change, health, and equity. Equality and equity are mistakenly used interchangeably. Equality simply means that everyone is treated the exact same way, regardless of their need or any other individual differences. Equity, on the other hand, means everyone is provided specifically with what they need to succeed. As Dave mentioned earlier, downtown in this image is a heat island, which can be up to 7 degrees warmer in the daytime and up to 22 degrees warmer at nighttime compared to surrounding areas. The reason for this disparity is something called tree equity. The organization American Forests has coined this concept of tree equity and assigned a tree equity score to most neighborhoods throughout the United States, with 100 indicating that a community has achieved optimal tree equity. Basically, the higher the score, the better. San Diego is actually designated as one of the top 20 U.S. cities with the most to gain by planting trees with respect to improving health and equity while reducing greenhouse gases. Here's a map of redlining in 1930s San Diego. Redlining is an example of systemic racism in our country in which the federal government designated Black, immigrant, and minority communities, in addition to low-income neighborhoods, with a low or red grade from which the term redlining was born. As you can see, all of Southeast San Diego and also neighborhoods like Barrio Logan were redlined and are now environmental justice communities with less resilient social determinants of health, such as healthful foods, clean air, safe space to exercise, high quality education, and good paying jobs. Perhaps you can spot a similarity between those redlined communities and those that have tree equity scores, which in these maps are delineated in orange. They're essentially the same. Systemic racism of the past has carried forward to the present and is affecting our patients' physical health and emotional well-being. So why is this important to us as healthcare providers from a climate lens? Redlined communities are at higher risk of heat-related illness due to higher temperatures, air pollution, and lower tree equity. Redlined communities lack resources and are more likely to suffer from and not recover from climate disasters like drought, wildfires, and flooding. Therefore, environmental justice is health justice. And that's where we come in. It's estimated that only about 20% of health depends on clinical care. The rest is derived from what we call social determinants of health, delineated here. These determinants of health include things like income, education, social support, health behaviors, and the physical environment. But if we leverage our positions as healthcare providers and trusted voices in our communities, we can affect the other 80% of non-clinical determinants through our community partnerships, volunteerism, education, advocacy, and strategic patient-centered initiatives. With intentional integration of climate and equity lens into our healthcare culture, we can be the solution to climate change and health inequity. So we'll close with some hope and empowerment. As physicians, we are privileged to have several spheres of influence. One, we are trusted voices for our patients. This particular group and audience here today are educators for our residents, students, and colleagues. We're key players in our healthcare system. We are health advocates, and although this is not the scope of today's presentation, we each have a personal carbon footprint. So let's talk about some of these directed solutions in summary. We are trusted voices for patients, so we must update our illness risks to include climate change and health equity factors. We have to consider medications that we're prescribing and reviewing from a climate change lens. We must prescribe nutrition and transit interventions that improve health and reduce greenhouse gases simultaneously. And we should be counseling patients about social interventions that prevent disease and reduce frequency and severity of exacerbations. As educators, we should be integrating a climate and equity lens into our mentorship of and our presentations to learners. As key players in our healthcare system, we can look inward at our own departments at ways that we can reduce our energy consumption and waste. We can advocate for sustainable investing. We can advocate for enhanced screening of social and environmental determinants of health. And we can advocate for targeted social and environmental interventions. And lastly, we are health advocates. We are very respected in the community. We are only second to nurses as physicians as far as the level of respect and reverence that the community gives us. So physicians and healthcare workers in general are very respected in our communities. So we can advocate at the local, state, national, and global levels for policy changes, something that Dave has been doing for many years and that I've started doing myself in the last few months. So I'll close with a very powerful quote by Gary Cohen, who's the president and co-founder of Healthcare Without Harm. The healthcare sector occupies a unique position in U.S. society, both as an economic behemoth and as a profession with an ethical commitment to do no harm. That power and purpose can be leveraged to take on the twin crises of climate change and inequity. To that end, we must expand the healthcare sector's mission beyond patient care to include healing communities and the planet. This is the new social contract between the healthcare sector and the communities they serve. This is the new Hippocratic Oath. So if we are intentional and collaborative, we can create a culture of sustainability within our KP. And right now we'll open up the last 10 minutes to comments, questions, anything that you'd like to include. Thank you guys for listening. You can also turn to the chat if needed.
Hey there. Hey guys, great talk, thank you. Just a question, not so much specific to resident education, because Dave, you and I have spoken about how to get the residents more involved, and love to see this plane kind of taking off. I think there's a great opportunity for them to learn and not just learn, but become advocates. and change agents. So where does methane sit in all of this? I've started to hear increasingly so about methane being released from glacial ice, and that actually becoming more of a concern for global warming than carbon dioxide. What have you heard about that?
You want to take that one, Dave?
Sure. I can tell you what I know. I think pound for pound, methane is far more dangerous to ozone and global warming. It just doesn't have quite as much of a footprint as carbon dioxide. Things like livestock production is a huge emitter of methane. There's been increasing knowledge of indoor air pollution as a result of methane gas in the home. And a lot of cities like Encinitas and Vista and Solana Beach are starting electrification processes where all new builds will not allowed to have any kind of indoor gas, which is critical for indoor air pollution. So yes, it's a heavy player in this for sure.
And a funny little anecdote about that, I heard this story last week that this article last week that there are some farmers, especially like back east, that are starting to feed livestock seaweed because it's found to produce less methane when cows burp. Burping is actually worse than like passing gas from below as far as methane emissions go. So there are all these creative climate solutions that are possible, that people are thinking of, that people are doing on smaller scales, and healthcare can definitely be part of the solution in a lot of creative ways. So that's why we want to really focus on changing our culture of education, but also wellness, quality, safety, everything. Any other questions on how you can apply this to your individual practice, to your education of our learners?
And we're always interested to hear, because we obviously approach it from family medicine and emergency medicine standpoints, but it's always interesting to hear other specialties and how and why they would incorporate this in. So sorry to interrupt, Matt. Go ahead.
Oh, no, just going to ask what you thought next steps were, just in terms of getting the residents a bit more involved, both on the FM and on the EM side.
Yeah, so I think it's important to start the conversation with them. I think you'll find that this is, as Rachel's data it really resonates with younger physicians. I mean, if you ask a 75-year-old person versus a 25-year-old person, their climate anxiety levels are really different. So I think on a personal level, I think this is really critical to their wellness. I think important, at least from my personal experience, to feel like one way that I can deal with kind of that eco-anxiety is to actually do something and actually learn about it and talk about it and figure out ways that you can kind of make your workplace. So I think the first thing is start the conversation with them, let them know that it's something that we're talking and hopefully get them more involved. I'd love to see them get involved. One of our graduated EM residents, Elizabeth Rivas, is a phenomenal speaker at public events and with city councils, and she's gotten really involved in the Public Health Advisory Council. And I'd like to see more of that if people are interested. I think it's important, most importantly, as Rachel really described well, to get those conversations with our patients individual level. I think maybe in the emergency department, there's probably less emphasis on that, but I think there's a lot they can do in terms of emergency preparedness as it relates to climate-related disasters. But I think also personally, it's good for them to have the conversation, feel like there's avenues that they can make a difference.
Yeah, I agree with all of that. And I have at least 2 residents now that, as part of their scholarly activity, will be doing research and then presenting at national conferences regarding climate inequity and helping to reduce those health disparities through climate solutions that are caused by, at least in part, by climate change. So that's another thing that we can naturally do, is we can use some of the requirements that are part of our residency programs, like scholarly activity, to embed this learning into it as well. And then Rachel Ireland from Pediatrics, thanks Rachel for your question. She's saying that it's a huge a huge conversation to open with families to help to address solutions for their current health problems, and what kind of 1-minute sort of nuggets or counseling pearls can we use with patients. So I think that this is very much so where it's a collaborative effort, because this is something I've personally just been trying to do, like one smart phrase at a time. I've developed like 3 smart phrases now in the last 6 months. One's about plant forward eating and active transit. And so I use that as, like, again, a 1-minute nugget. And then I use a smart phrase to reinforce that information. I also have one about air quality. And I speak with patients about how they're, and this is very applicable to pediatrics, obviously, but throughout the entire spectrum of life, including prenatal patients and their growing fetuses to our elderly patients, is I actually tell them about certain apps that they can have on their phone that they can access on a daily basis, or when needed, and they can look and see what's the air quality in their area right now, what is the allergy, like the pollen count, what's the allergy status in their area or their neighborhood, and they can use that to actually inform their decisions on a day-to-day basis about what activities they'll do inside versus outside. And then you can also sign up, and you can recommend to your patients to sign up for air quality alerts. Again, this applies to a whole spectrum of patients, but I would say that it's really helpful for anybody with cardiorespiratory disease in particular to reduce their risk for exacerbations and ER visits and hospitalizations. And there's one more I'm working on that I'm blanking on at the moment. I will let you know. But I think that these are all ways that we can look internally at our own practices and at our own departments to try to come together. And Dave and I, as I mentioned, along with Nguyen, are part of the green team for San Diego. And these are things that we want to take back to our regional green team so that we can have policies and protocols, and we can use the resources of region to help improve our patients individually and community-based. So thank you guys so much for all the awesome questions. Unless Dave has anything else to finish with, I think we'll let you go for your Wednesday afternoon. If you have patient care, enjoy, try to use the sun, try to mention climate change solutions to one of your patients a day. That's what I usually do. That's my recommendation. And we look forward to collaborating more in the future. Thank you guys so much.
Thanks, guys.
Thank you.